So are we thinking December 5th, nothing in November, December 15th, we do the dopaminergic discussion. January, we do cluster correction. You could ask Andrew to do February. And then in April, we do sample size, or vice versa. In January, do sample size and ask Andrew about cluster correction in February or something.
Yeah, I'll see which date works for him between January and February, and then whichever one doesn't, maybe we'll do the sample size paper in that meeting if there's no other topics.
That sounds great.
So the paper for today, I chose this one. It's a review paper I really like, and it's a few years old now, but I think a lot of the ideas here are still really valid, and I like that it spans multiple fields. So I'm someone who spends, and I know that Dr. Arrington spends a lot of time in the education space thinking about like reading change and all of that, but in terms of future health outcomes and neuropsychiatric disorders, this paper sort of goes through a lot of different areas of cognitive neuroscience. With this idea of prediction and the space, the place of neuroimaging in that. So I thought it would be useful to kind of talk about some of the considerations that surround these different areas of inquiry and what neuroimaging can do in these situations. And so I'm just going to, I have a little bit here about this idea of neuromarkers and individualized prediction. And then the paper goes through a bunch of different areas where this can be applied. And so Nikki will share with us some of her work looking at prediction of reading outcome, which as a sort of illustrative of the kinds of techniques that one can use in this area. And then I have a couple of considerations, which I'm hoping we can chat about afterwards as well. And I think the paper nicely sets the stage for a lot of this kind of discussion. And this idea of a neuromarker as well. So it's in the paper defined as an initial brain measure that can predict a future behavioral outcome. And that behavioral outcome can look very different depending on what's being investigated. But what I like about this paper is that they give lots of examples where a behavioral measure on its own, like let's say a clinical measure or questionnaire and assessment, something like that, was not able to predict long-term outcome. Yet, when combined with neuroimaging, the models were better able to predict. So the neuroimaging had an added value in terms of being able to predict longitudinal outcomes.
I'm sorry, Jeff, before we go too far, are we going to be recording this?
It is already, yes.
Oh, okay. I didn't see that.
I did not remember at the beginning, but I did about 5 minutes in. But thank you for reminding me. And the other thing that I thought was a useful point that the authors made here too is that oftentimes it's sometimes difficult to predict who will sort of go on to show different effects of treatment. It is not necessarily related to the etiology of the disorder or let's say the severity of the symptoms or something like that, but really it could be something else entirely that actually, a brain network or a measure of some sort that actually is predicting change in a way that is unclear if one were just to look at cross-sectionally, let's say, a group of patients with a disorder compared to those without. So I thought that the paper had lots of examples of effects like this. And kind of related to our discussion last time, I thought that these neuromarkers, we talked about variability and maybe that capturing some sort of plasticity in the system or there being a sort of state of readiness for upcoming change. And the extent to which these neuromarkers are actually capturing a brain state that might lead to optimal long-term outcomes based on the readiness of that brain network or system for upcoming change. So I thought that was a provocative idea as well. And the other thing that I thought was worth mentioning is that the paper draws a distinction between correlation and prediction. And this is something I'm guilty of it too, where I'll say prediction and really mean correlation. So sort of like if two measures are related to each other, that this measure predicts that one. Whereas the idea of prediction here really being about out of sample generalization. So having a model of some, let's say brain measure that predicts behavioral outcome, and then taking that into a independent sample of participants and seeing how well that model holds up. Using something like, for example, cross-validation. So, leaving out a portion of the sample, developing a model on a test set, and then using that, on a training set, and then using that model on a test set and seeing how well it performs, and iteratively doing that through different folds of the data, for example, or just having a completely independent sample, which some other papers have done too. But as they stated, only 11 of the 72 studies that they reviewed actually did this. So there's a lot of studies out there and longitudinal, kinds of investigations that really are only doing correlational types of analyses, and not taking this extra step to consider really the predictive utility of the different models that are out there. So that, I think, is something to strive towards working in this field as far as developing these kinds of models and using different techniques like cross-validation to do that. Are there any thoughts or reactions to some of that?
I think I remember a paper Vince wrote almost a decade ago looking at support vector machines and those kinds of analyses in fMRI, and making exactly the same argument that most of them are not doing their cross-validation properly.
Right.
It seems to be an ongoing issue.
And especially with, discussion about sample sizes and all of this in terms of generalizability, if you've got a small sample and you build a model on that, how applicable is that? Especially when we're talking about, clinical settings and things like that. I think that I haven't seen all that many papers that really use big data to answer these kinds of questions. And so there's a number of different areas here. The one I wanted to highlight that the paper goes through is treatment for neuropsychiatric disorders. And the reason why is that I thought this was a nice illustration. So they've sort of, the authors state that if there is some utility for this and that you actually use these neuromarkers to guide treatment decisions, that there needs to be alternative treatments available. So they're actually, in this case, in this example, was a study where there were either a behavioral or a pharmacological treatment, and that differentially had effects across participants, and that there was this really interesting interaction between the treatment outcome and then what was seen with respect to these different neuromarkers. And I actually went back to this paper because I found it quite confusing, so I hope I've got this right. But this one here, they're looking at the effects of cognitive behavioral therapy compared to a medication for major depressive disorder. And they found that between the remitters, so those for whom the treatment was successful compared to those for whom it was not, and that there was a difference. This was a PET study, so they were looking at glucose metabolism here. But they found this really interesting interaction where some areas showed a higher degree of glucose metabolism in those who responded to treatment compared to those who didn't. For example, the medication, but a reverse effect for the therapy. But then you see other areas where the direction of that is entirely flipped. And so this kind of thing, that if we had these sorts of measures, that could actually be used to decide whether or not the CBT or the medication might be the better route for a patient. So I thought to me, that was a striking example of how this might actually work in practice. And there were a couple others there that were mentioned. So future criminality, future health, for example, relapse for different substance abuse disorders. And then finally, with respect to education, there's been quite a lot of work actually in the area of reading. And so the team that put this together, quite a lot of the work that they do is actually in the field of reading development in children. And then also language learning, for example, in bilingual individuals. And so that, I think, nicely segues into Nikki Arrington's presentation. So Nikki, if I, would you be able to share your screen if I stop sharing mine?
Nikki, you're muted.
Oh, sorry about that. Yeah, I think I should.
Okay, so if I.
Okay, can you see that?
Yes.
All right. Okay. So as Jeff was saying, I do research primarily in the field of reading and education. And I thought that, we thought that some of my research would be particularly relevant to this paper because we're interested in predictors of change, both behaviorally, but also what neuromarkers might predict how a child will respond to reading intervention. So I'm going to talk about a little bit of the work that we have done with structural measures. So first, I kind of like to put this in context to kind of orient you into how reading is processed in the brain. And we know that reading is actually a very complex activity, which is mapped on top of a lot of underlying networks. But reading utilizes a primarily left lateralized network, and we see communication between different regions as this process occurs. And so we know that it utilizes both different cortical areas, but also we see relation between the white matter tracts that connect these regions. So we have a very nice, clear network associated with reading. With reading impairments, such as developmental dyslexia that we primarily study, we see issues with this reading network. So part of the questions that we ask are, what's going on in the network? And is there anything that we can see that will help us predict how well a child will respond to intervention? For this study that's conducted at GSU, it's a longitudinal study. It's currently in its 7th year of data collection. This data that I'm discussing covers the first 5 years of it, primarily looking at 3rd and 4th graders in the Atlanta area. So at the time, we had around 170 3rd and 4th graders with an additional small sample of 7th and 8th graders. And this included both children with dyslexia and typically reading controls. But for the vast majority of this data, I'm going to be discussing the 3rd and 4th graders that were identified by their teachers as struggling readers. So they may not necessarily be diagnosed with dyslexia, but they showed some reading impairment in the school. And then those children were screened ahead of time, both with behavioral measures, and then they also received a battery of neuroimaging measures, so structural and functional data. And then they received 70 hours worth of a small group in-school intervention. So usually about 3 to 7 or 8 kids at their school with a intervention teacher with the FAST program, which focuses on developing metacognitive strategies for decoding, because we know that decoding ability is necessary for proficient reading, and phonological decoding deficits are a primary symptom of dyslexia. So with this data, I was interested in the question of what structural properties do we see in these students that struggle with reading that may predict how well they will respond to this 70-hour reading intervention program. And we looked at volumetric measurements of both cortical and subcortical structures that we associate with that reading network, as well as white matter tract indices of white matter tract integrity associated with the reading network. So as a part of the study, they received behavioral testing at 4 different time points. And we looked at these underlying reading proficiency measures such as decoding, phonological awareness, and then higher order things such as fluency and complex text reading. And we were able to use these 4 different time points to create a reliable change measure. The reliable change measure was then, sorry, I just saw the question. So how long did the 70-hour reading intervention program take? So typically this occurred over the course of the school year. They received it 1 hour at a time, usually 4 to 5 days a week. So typically it was from, say, October to April. That sort of varied depending on the school and that sort of thing. But typically they received 4 to 5 hours a week for the length of the school year. Good question, thank you. So then we were able to use that information to, like I said, create these reliable change scores that then we correlated with the structural measures. So we took anatomical measurements, which were based on FreeSurfer reconstruction. I really like FreeSurfer for the for kids. We'll talk about a little bit why this is an issue, but FreeSurfer is an atlas-based segmentation that allows for us to get cortical thickness measurements and subcortical volume measurements. So for our sample, we did remove children who had any sort of severe psychological impairments or but we did not. So typically we see a high comorbidity with children with ADHD or language impairments. And as a part of the larger parent study, we were interested in those comorbidity questions, so they were not excluded from the sample. So the idea was to get a more valid view of what this classroom actually looks like, because too often in research, we try to really have a pretty clean sample, right? But we know that the classroom doesn't look like that. We have a really heterogeneous sample of kids. And so while still trying to maintain a cleanest sample as possible, we wanted to try to represent the classroom in its sort of holistic form, if that makes sense. Oh, okay. So like I said, we were able to collect structural data. We also did diffusion data, which gave us measure of white matter integrity. For this, we used Tracula, which is a pipeline within FreeSurfer, and it uses those anatomical markers within FreeSurfer to create a global probabilistic tractography. And for this study, we used fractional anisotropy, which is, if you're looking at diffusion data, is a pretty typical measure. But for this study, it's particularly interesting because FA is thought to be sensitive to microstructural changes. And for some elements of this, we're interested in how is the brain changing over the course of the reading intervention. So like I said, one of the reasons that I like FreeSurfer is that it is a little bit forgiving. And as you can imagine, collecting data with 3rd and 4th graders can be a bit of a challenge. So just looking at baseline data, so this is just before intervention, not the post-intervention data. We were able to collect for the whole sample, including the typical readers and the 7th and 8th graders, close to 200 structural data sets. And if you notice, we have more MP-RAGE data that was usable than we do the diffusion data. Part of that is a limitation of our the way that we collected data, because we did both an anterior to posterior and a posterior to anterior so that we could co-register that. It did make for a nice clean data for that we did get, but it limited the amount that we could get. Because for a typical 3rd or 4th grader, seeing something like this might be fairly common. And if you notice in this image, so the different colors is the segmentation of the different brain regions. And realistically, FreeSurfer didn't do a horrible job with this, but you can definitely see a lot of motion in here, which is pretty common for our kids. Because like I said, we didn't exclude, oh yeah, very wiggly kids. We didn't exclude kids with ADHD because that is a normal part of the sample. And because we were interested in this comorbidity question, we had kids that were very wiggly. So we had to come up with some creative ways to deal with that. But that being said, we did find some interesting results. So like I said, we took this, the structural data, and first correlated it with different brain regions that are associated with the reading network, as well as their right hemisphere homologue. And then those areas that were correlated with their pre-intervention reading scores, we then took those and performed a series of hierarchical regressions to look at which of those brain regions were predicted their reliable change. So this measure of how much change they had over the course of time. And we found for these very basic underlying reading skills, such as phonological awareness and decoding, that regions within the reading network, specifically the left inferior temporal gyrus and the right middle temporal gyrus, significantly predicted their response to reading intervention above and beyond any baseline reading measures. So you might notice that we have right MTG predicting decoding when I said that reading is thought to be left lateralized. Well, we do see a lot of activation in the right hemisphere and a lot of correlations with right hemisphere, these children with dyslexia. And it's thought that perhaps there could be some compensatory mechanism going on, because the right hemisphere is working in those regions where the left hemisphere isn't for these kids. When it comes to our diffusion measures, interestingly, we see predictors of those higher order, more complex reading measures, such as fluency and text reading. So we know that these skills take a lot more effort, a lot more utilization of multiple brain regions, because they're more complex. You have to put these things together in order to read a whole text, as opposed to just reading a word per se. And so we see the uncinate fasciculus predicting change in fluency and text reading above and beyond any baseline reading measures. So then we ask the question of, So if we see these predictors in white matter, what does that look like after intervention? So we did an examination of white matter before and after intervention. And interestingly, we saw some of these changes in FA, so increases in FA in these tracks that we also saw predicting change, particularly bilateral uncinate fasciculus. We also saw changes in some left hemisphere tracks that would typically be associated with the reading network, like the inferior frontal or the superior longitudinal fasciculus. We saw changes in these regions associated with reading. So kind of what does this all mean? What do we take from this? Is that perhaps cortical thickness can actually predict reliable change for these very basic underlying reading measures, such as decoding and phonological awareness, whereas our white matter integrity predicts change in the more complex reading measures, such as fluency and text reading. And perhaps these changes that we're seeing in the right hemisphere help to support the idea of these compensatory efforts that we see in the reading network in children with reading impairment. So as they improve in reading skills, perhaps some of these left hemisphere compensatory efforts are coming online to help them read better. But interestingly, and kind of the question that I posed to the group is, can these brain indices be predictive of both behavioral change and brain changes associated with reading intervention? So that's my two cents for the day. I want to thank the many people that are involved in this project. Like I said, it's a very long longitudinal study, so there's a lot of hands in the pot. So lots of thanks to them. And thank you to Jeff for letting me share this data. Okay, so just looking at some of these questions. So the question about whether the TBSS comparisons pre and post intervention included all participants, good versus bad responders. So this did include all of our struggling readers that had usable data pre and post, which naturally brought the sample down a little bit. I think for that sample, we had about 60 kids. It was just the 3rd and 4th graders, regardless of their response level. We have done some things looking at good versus poor responders. So those kids that we saw that responded really well to intervention versus those that maybe showed very little response. That right now, we're still working on it because we're still doing data collection, trying to get our sample size up, because right now it's kind of small to try to do those comparisons. But that particular data included everyone. Good question.
May I ask my questions?
Absolutely. Please do.
Okay, thank you. So follow up on the Jeffrey's presentation. Would you explain how you calculate the predictivity? Because you are saying they are predictive. So would you explain how you measure that?
Right. So this kind of goes back to what Jeff was saying about how we use the word prediction and whether or not it actually. So we used a hierarchical regression model and included some of those baseline reading measures that we would expect would be related to post-intervention change, and then included the structural indices sort of at the end of the model to see if they still accounted for change above and beyond some of those other measures. So how you want to take that on whether or not it's considered prediction, that's up for discussion.
My second question is, I noticed you also collect fMRI data, and we see that so many times when we are talking about a compensatory effect, they also look at the functional connectivity. For example, in brain injury, at least in my study, I saw like when there's changes, like in the acute stage in the structure, we have a structural damage, we can see a clear compensatory effect in functional connectivity over the time. So I was wondering if you also look at the functional connectivity, especially when you are talking about the left and right hemisphere or not.
Right. So it's not something that I have actually looked at in this data. We have another group, and Jeff is one of those people that looks at a good chunk of the functional data. But that's definitely something that we're interested in for sure.
Yeah, and I can jump in and say that, one of the things that we're interested in is also like variability, like we talked last time, whether there's different indices. And, we certainly talked about how that relates to connectivity as well. And so we're interested in that. So a lot of the past studies in reading intervention have tended to implicate like right prefrontal areas as being predictive of change. So I think, whether that's like maybe a transfer from the right to the left, or whether that's even the age that we're looking at, maybe, these children, if they've struggled with reading for a couple of years at that point, maybe starting to use some of these right hemisphere circuits a little bit more. That gets really tough to disentangle the older that you go in terms of different, groups of struggling readers. But that's where we would expect, or at least I would expect to see this kind of effect would be especially in those right prefrontal areas.
It's also why we have a small subset. The data that I presented is only our 3rd and 4th graders, but we do have a small subset of 7th and 8th graders that we're interested in making those comparisons. And do we see differences or similarities between the two groups? 7th and 8th graders are a little harder to get, but it is an interesting sample that we want to pursue.
Can I ask you a question?
Absolutely.
I was, obviously this is a time of a lot of change in the brain anyway. Do you have a way of teasing this apart from, just the kids who happen to be maturing appropriately versus slow maturing, something like that?
Yes, absolutely. So that's why we included the typical reader sample. We're in the process of running those analyses now, so it wasn't data that I've put in today. But that's our goal, is we have the typical readers are from the same schools, the same backgrounds. They go through all of the behavioral assessments, but they don't actually get the reading intervention. So we can do that. Yeah.
All right. And would you be open to trying to do some specifically predictive kinds of approaches on this?
Absolutely, yeah. And that's definitely the long-term goal of the study as a whole.
There's something I was interested in Jeff's in the paper that Jeff was presenting on is their presentation of how you do these kinds of predictions and sort of what I think of as machine learning approaches to these predictions and the generalizability. But of course, machine learning techniques for non-neuroimaging can use very different algorithms. And I was particularly thinking about if we try to get to the point where we can do a brain scan and then predict treatment based on, a number of studies, we'd want to make sure it's really robust. And I was wondering if anybody's on the call who's done machine learning has familiarity with sort of adversarial training, where you actually you basically build a network and then you build another network that tries to trick the first network. And they basically, train each other like kittens. They play together and they learn from each other's errors to come up with something that's really robust, hopefully. Usually people try to, hackers try to use it to break facial recognition systems or try to prove that a particular algorithm is not doing what humans do or not as good as a human. But nonetheless, I wasn't sure if that's ever been done in neuroimaging per se, and whether that would help address some of the issues that we see with overfitting and things like that.
That's a great question.
Yeah.
I think especially with some of these structural measures that it would be something that was feasible.
Yeah, exactly. Exactly. Although I don't know how, usually they're working with data sets of thousands of images. I don't know where that, what, with 100, I don't know what you could actually do, but it would be interesting.
And Nikki, something I wanted to raise as well that I really like the point you had made about sort of depending on the measure that you're looking at, the different neuromarkers might contribute to that. So in one case, it was, some of the more structural measures, and others it might have been maybe the DTI measures, that, sort of the extent to which we can collect all of these different modalities and use them, in tandem in these different models. I think that's where there's more power there, rather than just only fMRI or only EEG or something like that. So I liked that idea.
Yeah, for sure. I think the more data we have, the more informed we can be, and I think that goes for imaging data for sure. Because especially when you're looking at something as complex as reading, we know that we have this complex network that fits on top of all of these other networks, like vision and hearing and language. We can't just look at one piece of the puzzle, because then we're missing out on so much at the big picture. So
actually, that's an important question. Among the students that you're working with reading disabilities, do you know what their eye control is like? Are they able to track and moving objects and control gaze?
So we did do, not really eye tracking per se, but we did some experimental measures that looked at elements of their visual processing. And that's sort of one of the questions of the study as a whole is, are there some of these visual elements, not just but thinking about how well they break down the word and that sort of thing. But we didn't really do any just motor-based eye tracking kind of assessments.
Because obviously, as you pointed out, there's a lot that goes into reading disability.
Absolutely.
And there could be dysfunction in a lot of different processes.
For sure.
Interesting.
Yeah, I think the one task I'm thinking of, Nikki, but I'm not sure of the data from that, but it was looking at, I think it was the different letters and ways where they were sort of occluded in some way, and looking at perception of these different visual symbols. That's probably the closest, I think, to that kind of thing.
Yeah, that's what I was thinking about as well.
But there was other data that more looking at like statistical dependencies. So like certain stimuli that would appear on the screen in certain places, and remembering that and that kind of thing, as opposed to being, solely linguistic.
Right. Yeah. Yeah. Interesting. I look forward to the multimodal integration of these.
Yeah, I think we need that. I
very
like
much
that's
so.
why this paper I think is a really useful guide on how to do that kind of thing.
Yeah. And it's a good data set for it. Though obviously the more modalities you ask for, the smaller and smaller the sample gets.
That's very, very true. I will say that was one of the things that I was pretty proud of over the course of this study. Our data collection got better and better. Just kind of putting together a nice protocol to train the kids and help keep them still, because even just the order in which you do the sequences makes such a big difference with these kids.
Yeah.
So often we want to like front load the important stuff, like all the functional tasks, and do all the rest of the stuff at the end. But then by the end, the kids are fatigued. So we found that staggering things and putting the structural scans in between, where they get to watch Netflix and just kind of give them a break, made a huge difference.
Yeah, I think that especially with the functional measures, we've been working with that. And it's especially for variability, for example, where it's so sensitive to motion. But yet a lot of the sample that we end up having to exclude are the very kids that we're most interested in.
Yeah,
So
it's not
really
missing at
something
random anymore.
Exactly. We're really grappling with that.
Yeah.
And one thing I wanted to bring up too, which I like that the paper made this point as well, of and it's a point I often make when talking about this kind of educational neuroscience sort of thing, is that, you know, I think it's, rather than maybe saying that it's feasible to sort of scan all children and have neuromarkers predict reading outcomes, I think that's, you know, not feasible in many circumstances. But rather having sort of tying it back to behavior. So if there's certain behavioral assessments or tasks that we know are linked to brain outcome, you know, maybe that can inform the types of behavioral measures we're actually using. So they use this term of these brain validated behavioral measures, which I kind of like, that's using that knowledge, you know, of the studies that we've done to guide what we might be using in the classroom or clinically, without necessarily having to like scan all individuals, you know, with a certain disorder or something like that, because there's all sorts of questions about accessibility at that point.
But you don't want to over refine a few studies either, or over generalize a few studies and say, oh, well, you know, clearly we know that this task affects the brain, or the intervention affects the brain, when it really only affects, you know, highly motivated kids in Palo Alto or something like that.
Absolutely. That's a great point.
That's an issue we're seeing with all of the Alzheimer's disease research. Works great for a certain cut of the population, not so much for everybody else. Interesting.
We've seen some of that in our own data. Jeff and I have been comparing some of the functional data. And so we have a sample that was collected at UConn in Connecticut, which, and then that data here that we've collected in Atlanta, which are very different samples of kids.
Yeah.
And it's very interesting how, as we're trying to like validate a task, even on that level, the kids look very different. So you have to ask this question of like, who are we testing, right?
Well, I remember when we were doing the multi-site, you know, schizophrenia studies, and we had scans from California and scans from New Mexico. And for some reason, in the early pilot studies, the scans from New Mexico, even though it was identical scanner, identical protocol, just had tremendous bold signal changes, which we weren't seeing. And we were joking around, it might be that they were at high altitude, you know, compared to, you know, sea level. Because we know about the effects of, you know, training at high altitude and what that does. I don't know that we ever nailed that down, but, you know, it's things like that you just want to, you know, you just don't even think of until you start generalizing it to multiple scanners and samples and things like that.
Right. Yeah, that's why I chose that one, the study that I showed the slide for with a major depressive disorder, because I found that so striking that it's like the exact reversal in some cases of depending on the treatment that was selected. And had you just, you know, had things not been examined in that way and sort of just assumed that, you know, it was kind of a one size fits all approach, like that's not going to work for different samples. And so I thought that was, I think, kind of studies like that and need to be done a lot more, even with reading as well, you know, the different kinds of instructional techniques. What do the outcomes look like, to actually get to the point where we could decide, you know, for an individual child, what technique might be best, which is, you know, that's kind of, we always say that's where we want to go, but there's so many barriers to getting to that point.
It takes a lot of effort. There's a lot of aspects to that. Yeah. That have to be tested. Fascinating stuff.
The one other thing I thought was really also fascinating too is just that how early some of these effects are, you know, some of the ERP studies that they're saying that, you know, a few hours after birth, predicting reading difficulty, you know, at age 6 and 7, like the extent, it seems like a very deterministic kind of thing. where, so early in life that there's these kinds of markers, but at the same time, we also know in reading intervention that earlier is better. So it's, if these kids at a really young age, even if they're pre-reading, something that can be done with language learning, when they're toddlers can actually improve, reading later on. That's again the kind of thing, if we're able to get, but again, working with infants, it's even more challenging. So it's, but that's, I think there's a lot of room there too to think about that.
That's actually an important point because, when we talk about norms for development, we intervene when kids are not meeting, whatever the percentile is for on a particular scale. And, but what those scales are all has to do with what do we think is important, like they can't articulate well at ages 3 and 4 or something. And you get a therapist to work with them on, how do they actually speak. Or, or they're not paying attention in class, they're not reaching whatever that is, and you try to work with that. But if you could say, look, or the APGAR scale when they're born, the color's not right. We know that's a bad sign, you want to deal with that. So if you could just do a brainstem thing, it says, okay, this kid's going to have linguistic issues in 2 years. All right, let's work with that. That would be amazing. But we don't, until we know for sure that that's worth knowing about and intervening on, we can't develop the norms for it.
Yeah, absolutely. And especially with reading that, it's the current model in a lot of schools is this like wait to fail, as it's called,
right.
Sort of idea that, a response to intervention model, or if the child does not show a response, then get them into an additional program or something like that. But it's sort of, at that point, the child's been struggling for a long time.
And the frustration and the learned
right.
helplessness and all of the negative, aversive stimuli. Oh goodness. Yeah, no, you'd want to cut that off before it gets too serious.
Right. So I think that's a real place where neuroimaging has a strength, where sort of even before there are overt behaviors, like let's say, reading, that, the child is pre-reading, and yet there's still certain measures that can actually be used to predict upcoming change. And also, I mean, even just from the administration of these interventions, I mean, it's a lot on the part of many people. And so really deciding, when's the best time for that and which intervention's best is really important.
Fascinating.
Well, thank you. And thank you, Nikki, for presenting that work.
Absolutely. Thank you for giving me the opportunity.
Yeah.
We'll hear from you in a year, right? With the multimodal stuff.
And so I suppose we'll have our next meeting then in December.
Sounds good.
All right. And and we'll post the recording for those of you who had to leave early or missed it. And we'll see you next time. Right, thanks again.